for the opportunity. Welcome, everybody. I know it's kind of an interesting time to be logged in and not listening to any news organizations. Hope this will be a nice break for you. And I can't wait to ask Mike DeAngelica some questions about pancreatitis. But let's introduce Patrick Mclaren, who's got a great talk on pancreatitis to drain or resect. So Patrick, take it away.
All right. Well, Patrick Mclaren. I'm the fellow here.
Patrick, we lost you. You're muted.
Patrick, are you back? Sounds like the host muted everybody for a second.
Can you all hear us now?
Patrick, yep. Yes.
All right. You can hear me now?
Yes.
Okay. Sorry about that. My topic today is pancreatitis to drain or resect. I'm the fellow down here in Texas with Dr. Jay Raja. So let's go ahead and get started. So today, just a brief overview of my talk. We're going to go over a few definitions of pancreatitis, chronic pancreatitis specifically, talk about some indications for surgical intervention, and a general overview of the approach to management of patients with chronic pancreatitis and when we make that decision to proceed with surgical intervention. And then quickly we'll discuss not all of it, but many of the procedure choices that are available. There are a number of surgical options and non-surgical options, and there isn't always a right answer, which is why I found this to be an interesting topic, and hopefully there'll be some good debate amongst people what procedure is the right choice. And discuss some of the imaging options because that's critical in making the diagnosis of chronic pancreatitis. And then at the end, hopefully should take up most of the time with our case presentations. We have some hopefully interesting cases to discuss. So before we get into anything, I just want to define what chronic pancreatitis is. And I set out to make this talk about chronic pancreatitis, and I found that actually be a little difficult defining a hard line between or making a talk all about chronic pancreatitis without at least mentioning acute pancreatitis. So chronic pancreatitis is defined in Blumgart as continuing inflammatory disease of the pancreas characterized by irreversible morphologic changes that typically cause abdominal pain and or impairment in pancreatic function. And I think sort of the key word in this is the irreversibility. So, and why this is important is because acute pancreatitis and chronic pancreatitis, although related diseases and a continuum of similar diseases, are two clinical entities that are treated very differently. So just to define, acute pancreatitis is acute inflammation of the pancreas that has resolution, whereas I mentioned before, the irreversibility of that inflammation and fibrosis is where we enter into the chronic pancreatitis. Now, patients often can have episodes of recurrent acute pancreatitis, which can develop into chronic pancreatitis, and making the distinction clinically can drive our clinical decision makings and is important. So, first of all, just kind of an overview of our approach to chronic pancreatitis. The most important thing when first making the diagnosis is establishing a cause and removing that source if possible. The most common cause of chronic pancreatitis in the Western world is alcohol. So stopping alcohol consumption is of utmost importance in patients with alcohol-induced chronic pancreatitis. And then we get on to the initial medical management. So medical management is aimed at symptom relief. Now, when we have irreversible fibrosis of the pancreas, we get endocrine as well as exocrine dysfunction, as well as probably the most debilitating thing with chronic pancreatitis is pain control. So these patients need pancreatic enzyme replacement, management of their diabetes, and then ultimately in pain control. Now there's a step-up approach to pain control, starting with your anti-inflammatories and eventually moving to narcotic pain medicines. But approximately 50% of patients with chronic pancreatitis will ultimately develop failure of medical management, and you see listed some of the causes or some of the indications of failure of medical management. Persistent severe pain and dependence on narcotic medications is, as I mentioned, probably the most common and most debilitating thing that we see. And also obstructive symptoms, so obstruction of your duodenum, your GI tract, obstruction of your biliary system, pancreatic duct strictures, and then also complications associated with cyst formation from recurrent attacks. And then finally, malignancy. So chronic pancreatitis puts you at about a 4-fold increase of malignancy as compared to the pancreatic malignancy as compared to the general population. And when we make that decision for surgery, once we have one of these indications or failures of medical management for surgery, is a topic of debate. But as I mentioned, 1/3 to 2/3 of these patients will end up failing medical management and require some sort of intervention. Now, that intervention can be endoscopic or that can be surgical. There have been 2 randomized controlled trials, and this data is from a Dutch trial looking at surgical procedures versus endoscopic procedures. And both of the trials showed that in the long term, chronic pain reduction was superior with surgical intervention versus endoscopic intervention, although in general practice, most people will attempt at least a step-up approach, applying endoscopic intervention first, as it comes with significantly less morbidity initially. So when we decide on intervening, when we have one of those indications for intervention, persistent severe pain, obstruction, you can go down sort of one of 3 pathways: the endoscopic or non-surgical pathway, and I should say endoscopic or interventional. And then your surgical pathways can broadly be defined as either drainage procedures or resection procedures. And as I mentioned, if we end up going endoscopic or non-surgical, about half of those patients end up needing a surgical procedure. So when choosing the surgical procedure, you need to look at the symptoms and the associated complications that those patients have. Now, broadly speaking, surgical drainage is indicated in patients who have symptomatic cysts or fluid collections, and in patients with dilated pancreatic duct without any evidence of disease within the head or mass or concern for malignancy are the times we would consider a drainage procedure. And then you have your resective procedures, and resection is often combined with a drainage procedure, and the indications for resection procedure include small duct not able to be drained, biliary obstruction, duodenal obstruction, inflammatory masses, and then obviously in the setting of concern for malignancy, it would require a resection. So just a broad overview of the types of procedures. This is not all of them, and all of them have some modifications, but your purely drainage procedures are cyst gastrostomy or your Pusteaux operations. And I should say cyst gastrostomy, cyst jejunostomy, cyst duodenostomy, so it is cyst enteric drainage procedure. Then purely resective operations, the Whipple, which we're all familiar with, distal pancreatectomy, and total pancreatectomy, plus or minus islet cell transplantation. And then the combined resection and drainage procedures include your duodenum preserving pancreatic head resections like the Fry, the Burger, the Burn, and the Whipstow procedure, which we'll talk about a little bit later in the talk. Just when considering which of these operations to do in a patient with chronic pancreatitis, it's obviously important to consider the location of the disease. So If you have isolated head disease, a head resection would obviously be a better choice than a tail resection. But as I mentioned before, pancreatic ductal dilation, so a Pisteau operation can only be performed when you have approximately 7 mm duct. Whether or not you have biliary obstruction, so is the procedure you choose going to offer a biliary drainage in the procedure as well? Whether or not the patient has gastric outlet obstruction, and then finally, again, concern for malignancy. So just some quick simplified indications for these operations. Cystgastrostomy indicated when you have an isolated or symptomatic cyst, symptomatic fluid collection. And I think it's important to make a distinction between pancreatic fluid collections, between pseudocysts and walled-off necrosis, as pseudocysts contain almost entirely fluid, whereas when you have debris material, you enter the walled-off necrosis definition. And while pseudocysts are readily drained endoscopically with stents, when you have walled-off necrosis, drainage endoscopically becomes more difficult with clogging of your stents, and a surgical drainage should be considered. Our second drainage operation, the Pisteau operation, is indicated when you have pancreatic ductal dilation without evidence of head disease or an inflammatory mass. If you have disease within the head, you need to consider other operations. Again, the Whipple, which we're all well aware of, when you have suspected malignancy within the head, irreversible stenosis of your duodenum, or localized disease within the head, which we'll have one of our case presentations involves some localized proximal pancreatitis. Distal pancreatectomy is again for isolated distal tail disease. One of our cases will deal with ductal disruptions as well, and when a resection of the tail is indicated, often a sequelae of necrotizing pancreatitis, and when you have strictures located distally. And then finally, the combination drainage and resection procedures, the duodenum preserving pancreatic head resections. In the first column, you see the Berger operation, and this is a pancreatic head resection combined with a division of the pancreas and a end-side anastomosis to the pancreatic duct. This is indicated when you have an inflammatory mass in the head of the pancreas causing significant pain, however, is contraindicated when there's evidence of malignancy. The Berger operation was modified to include a lateral pancreatic jejunostomy, which is the Fry procedure that you see here. And that is indicated when you have head disease as well as a ductal obstruction or distal disease where you need to drain both the head as well as the tail. And then finally, the burn modification, similar to the Berger operation. However, it's not uncommon that there is a reason why we can't divide the neck of the pancreas, specifically when there's portal hypertension or significant inflammation that would be a contraindication for division. This is a simple head resection and side anastomosis. So finally, before we get into the case presentations, I do want to talk about the imaging available for chronic pancreatitis, because imaging is paramount in making the diagnosis of chronic pancreatitis. And there's a number of modalities available, and I don't think that there's one single imaging option that is the single best option for any given case. So all have their pros and cons. ERCP has classically been the sort of gold standard with regards to imaging of the pancreatic duct. It's most sensitive for side branch and main duct strictures. But as we know, ERCP is an invasive procedure and carries a real risk, about 3 to 7% risk of developing ERCP-associated pancreatitis. So oftentimes we can make the diagnosis and make a determination on a proper treatment course without having to undergo an invasive procedure like an ERCP. CAT scans are probably the most common initial imaging that we use, which they are excellent at imaging calcifications and pancreatic atrophy. When compared to MRI, though, CT scan is inferior for imaging early chronic pancreatitis and morphologic changes within the pancreas itself, as well as imaging small cysts and the pancreatic duct. And then discussing MRI and Mrcp, as I mentioned, it's significantly better at identifying early changes associated with pancreatitis. Diffusion-weighted imaging, it helps in identifying malignant lesions. And then an important thing to talk about is the addition of secretin stimulation to Mrcp. This is, and I don't know if this is something that everybody's familiar with, but it is a dynamic imaging technique with MR where the patient is delivered a dose of secretin while undergoing MR, and the pancreatic duct dilates in response to the secretin stimulation, and it allows nearly as sensitive of imaging of the main duct as well as side ducts as compared to ERCP. It also is helpful in making the diagnosis of chronic pancreatitis in that patients with chronic pancreatitis have a less compliant pancreatic duct, so we don't see the dilation that's typically seen, and also excellent for imaging strictures. So that's a great tool to have in your pocket for managing and imaging patients with chronic pancreatitis. And then the drawbacks of MR, of course, are all of the normal things that we see with getting MRI, motion artifacts, patients with implantable devices, and claustrophobia can be a little bit of a problem. And then finally, come to endoscopic ultrasound, which is sort of becoming more standard across the board and allows us the advantage of tissue sampling that you don't get with the non-invasive measures. So if there's a concern for malignancy, there's an option for tissue biopsy. One drawback is that it's operator dependent and not all EUS is created equal. So with that, let's get into the sort of meat of our discussion and the fun part of the discussion, unless there's any questions or comments before we go on to the cases.
Patrick, that was great introduction there. I'm just going to take one question, just a few points for discussion here for the group as we get ready for your 3 excellent cases. You know, I know some of these procedures, you know, are not well, how should I say it, well promulgated or promoted. I'll let you know, for example, my own training, I had never performed a fry or a beggar, but did have the luxury when I joined practice with Dr. Helton, who had extensive experience in this. And so I'm just kind of curious, taking around the group here, who, you know, these fellows, you can just do a quick sort of hand raise, who has actually done a fry or a beggar in this group?
So you've got a reaction button at the bottom. You can hit that with a hand up.
Oh, there we go. Okay, so like I said, I think it's good to there we go. Now we're getting some images there. So very few I see. So I think it's good to actually kind of review some of those, some of that anatomy and the indications more importantly. Only other question we had in the chat was about risk factors in pancreatitis with pancreas cancer. And I think that's one thing to kind of keep in mind. We always worry about, the chicken or the egg phenomenon, but keep in mind that a lot of the patients that have had that have an elevated risk of pancreatic cancer are those with hereditary pancreatitis. So, the SPINK1 and PRSS and so forth. So let's keep that. Okay, go ahead, Patrick, carry it away.
All right, our first case, this is a 40-year-old male who had his first episode of an acute pancreatitis in 2015. At the time, the patient was a heavy daily alcohol user, and it was suspected that this was alcohol related. He was counseled and did quit drinking at that time. However, a year or so later, had another episode and again recurrent episodes of acute pancreatitis attacks on into 2018. The patient was managed at that time with a celiac block and had excellent relief of his pain for about a year and a half. Should also note that during that time, the patient did receive a cholecystectomy, which is a common theme, I think, in a lot of these patients with chronic pancreatitis. And we can discuss whether or not that's indicated a little bit later. So he, after about 18 months of relief from his celiac block, had another episode in February of this year where he presented, this was an outside institution, with CT evidence of focal pancreatitis within the head, as well as inflammation about his duodenum. He underwent an EGD with EUS, which showed a partial obstruction in his second portion of his duodenum with inflammation and no mass within the pancreas, and did have a biopsy at that time that was negative for malignancy. He was managed non-operatively, conservatively, with pain control and GI rest, and had resolution of his symptoms and was discharged and had a repeat CT scan a month later, which showed resolution of the inflammation about his duodenum without evidence of pancreatitis. However, a few months later, he presented to our institution in July of this year with the same symptoms of epigastric abdominal pain, nausea, vomiting, inability to tolerate PO. I should note that he had been started on pancreatic enzyme replacement and counseled on low-fat diet in the past prior to him reaching us. And at this point had started to lose weight and was requiring daily narcotic pain medicines that was interfering with his life. He was no longer able to work. And we have the CT scan from this presentation in July. So if anybody wants me to stop it or pause it at any point or has any comments on what they see, please weigh in.
I think that looks good. Keep going, Patrick.
All right, so as you see, there's minimal inflammation about the head of the pancreas, as well as some duodenal inflammation, but the majority of the gland was relatively normal without any evidence of dilated duct. He did undergo an EUS at that time, which again did not demonstrate any masses, no dilated ducts, just stranding and hyperechoic foci within the pancreatic head. He was treated conservatively, again this time with pain management, with symptom resolution and discharge, however, represented about 3 weeks later, again with recurrent symptoms. And so now he's had, over the course of 5 years, probably close to 10 or a dozen hospital admissions for similar symptoms. And this was his CT scan now on presentation 3 weeks later. And you can see here the focal inflammation around the duodenum and the pancreatic head in the pancreatic duodenal groove has worsened, and we start seeing a cystic formation here. So it brings us to our first set of questions to pose to the audience here. This is, like I mentioned, a patient who's undergone he's been admitted 10 times or so. At what point do we define failure of non-operative management and determine that he needs an operative intervention? And I think this is there's no clear answer, so all opinions are welcome.
That's a good place to pause there, Patrick. So let's just go around. I'm gonna see who's online here. So I see Jay Berquist from Stanford. So how would you guys respond to this patient with those two questions in mind?
So, I mean, I think that the patient has pretty clearly failed non-operative management. I don't know that I have a specific threshold cutoff, but 10 admissions and failure of blocks and inability to tolerate oral medications, I think suggests that he has failed it. In terms of when to intervene, he has on the second CT scan quite a bit of fluid and inflammatory changes in the pancreatico-duodenal groove, which is a little bit concerning. In terms of intervention, would like to see that get better. I don't have a ton of experience with groove pancreatitis, but I would rather do an operation on a patient with the first CT scan than the second one.
What operation would you do?
So I think that in my experience, you can't see his duct on either CAT scan, so it looks like he has a small duct. And I think it would be good to know, does he have a stricture? So, a specific location where he would, need to be resected past. But I think that the options here would be either a Whipple or a total pancreatectomy with islet autotransplant. And I think that the choice between those two would be predicated upon, whether he has a specific point of stricture or not.
Got it. I think we had a question from Mo. Is that right? Anything to add?
I was just wondering what was his IgG4, if that was checked or not.
Patrick?
It was not checked, no.
Okay. How about hearing from John Jerry, Providence, Portland? Would you do anything different?
Hi there. Can y'all hear me?
Yes.
Yeah, I think in this case, we don't have a lot of experience here at all with auto transplantation of islet cells. But looking at this, I think this would get a Whipple. I think the the duct is small, like Jay mentioned, and so our experience in these cases is we've done a lot of internal external pancreaticojejunostomy stenting. We think that mitigates risk of PJ leak, kind of turning people that might be susceptible to grade C leaks, the grade C fistulas, into more B or just biochemical leak. And so that's what I think we would do for this guy.
Do we have anybody that would do total islets here? Any centers? I'm trying to look around the room. I know we didn't cover that, and that might be a separate. I don't know if size group or anybody from MUSC.
Courtney from Cleveland, right?
Courtney?
We do them at Cleveland Clinic. I've done a few already. Can you guys hear me?
Yeah. Would this patient fit your protocol?
Yeah, well, they have to pass a very rigorous preoperative multidisciplinary group. I think the fact that he was drinking, is he actively drinking still, or it was just that he had a history? That would preclude him from getting it.
No, he had quit.
Okay. Yeah, so I think, they have to go through a number of things, including a differential pain block to confirm it's visceral pain that he's definitely having. Usually, if they have, and this person looked like it didn't have a completely atrophic gland yet at this point, so that would be actually, good for him, because we tend to actually err on the side of doing it earlier rather than waiting for them to have, a pusto or Whipple or something where basically that's going to diminish the yield from their islets. The psych evaluation, they do fasting tests and all those sorts of things. But as of right now, pending passing those, like he would probably be a reasonable candidate for that.
Okay. All right, Patrick, why don't you tell us what we did so we can keep the discussion going?
All right, so we took him to the OR for a Whipple. So we diagnosed this clinically as groove pancreatitis, and on pathology, the diagnosis of groove pancreatitis was confirmed with acute and chronic inflammation localized to the pancreatic or duodenal groove, and no evidence of AHPBA or malignancy. He actually did extremely well with near complete resolution of his symptoms and was tolerating diet and gaining weight, and was able to get off pain medications and is back at work. So this was a success story for a patient with groove pancreatitis. I chose to discuss this case because it's a rare entity, and I think it's something that is not commonly encountered and we should be aware of when dealing with these patients. Commonly, groove pancreatitis can be mistaken. I think in this case was probably mistaken up front, even in when we saw him initially, as just bouts of recurrent acute pancreatitis. But groove pancreatitis, this paper here was a presentation or a series of, I believe it was 11 cases out of England that showed great success with Whipple. All 100% of their patients had near complete resolution of their pain. And I think it's an important entity to be aware of, and that in this case, and in our case, Whipple provided a great benefit.
Great. And then any issues with post-op recovery, fistula? I mean, I know that doesn't happen in Texas, but.
No, so he had a soft gland, he had a small duct, so yeah, obviously was a high risk for pancreatic fistula. We did not have any issues with that. He did have a GI bleed post-operatively that was self-limited and was able to go home post-op day 7 or 8, but not with fistula. He did actually really well. Most of the patients that we're doing Whipples on aren't generally healthy 40-year-old patients, so he kind of zoomed through his recovery.
And
I wanted to ask the group and ask you, especially since you have such aggressive endoscopists, if you were entertaining the diagnosis of groove pancreatitis, would you have treated this more aggressively endoscopically prior to surgery?
Rohan, who was that directed to?
Well, potentially to you, but
okay.
aggressive interventionalists. But I just
Sure.
wondered if anyone else also would like to comment, because with groove pancreatitis, some people talk about repeated stenting and trying to sort of help that groove basically that has a very clear pathologic look. When you look at it under the microscope, there's a very clear infiltrative nature to the exit of that pancreatic duct. Are you guys more aggressive endoscopically, or would you have gone to surgery?
Well, I can have maybe Dr. Kirks or Dr. Saji can answer from our group.
I think you're correct that there are some very aggressive endoscopists here, but I think that when we've brought them into the field for really aggressive pancreatic ductal intervention, would be for patients with pancreatic stone disease or patients with a dilated duct and suggestion of a focal stricture, rather than this case, which appeared to have more parenchymal changes without an isolated ductal dilatation.
Yeah, I agree. All right, Patrick, let's move on to I want to get to the other cases as well. So unless any pressing questions. Yeah,
Can I make one quick comment and maybe a question linked to it?
please.
Someone brought up IgG4. Now, I know very little about chronic pancreatitis, but I do know something about autoimmune pancreatitis. This is not a typical presentation for autoimmune pancreatitis at all. It's usually a pretty painless mass that obstructs the bile duct sometimes. Is that part of your workup for someone who presents more like this, chronic pancreatitis? Would you include that? Although I would put that extremely low on my list.
Much as I would say here we've been pretty selective about who we've ordered an IgG4 on when we have a high suspicion of autoimmune pancreatitis. And
I would say it mimics malignancy more than it mimics pancreatitis. The other thing is when you guys talk about internal and external stenting and different ways of doing pancreatic jejunostomies, I think to improve the quality of this, you guys should all refer to a trial or refer to data. Lots of people have lots of ways of doing pancreatic surgery. Most of them have been proven to do nothing except perhaps make the surgeon feel better about what they're doing. But if you're going to mention external stenting, you should mention the randomized trial from Hong Kong, or you should circulate trials among the group, because otherwise we're wasting our time doing clinical trials. So I would shy away a little bit from just telling you what your experience is, and refer more to data. And I'll shut up after that.
All right, let's move on to case 2.
All right, case 2 is a 43-year-old male with a history of heavy alcohol use who is being treated with high-dose steroids for a neuropathy, who had a suspected drug-induced pancreatitis attack dating back to 2018, followed by multiple attacks requiring hospitalization. In November of 2019, had an episode of necrotizing pancreatitis, and this is his imaging from that time. So you can see his gland is, he's got a necrotic gland with fluid collection formation within the abdomen. And he was treated at that time with percutaneous drainage and ultimately recovered from his episode of necrotizing pancreatitis. However, as I mentioned before, the acute pancreatitis often develops into chronic pancreatitis. So over the course of the next year, he developed chronic pain syndrome, was an insulin dependence, as well as requiring pancreatic enzyme supplementation, and as in the other case, underwent a cholecystectomy. He represented in July of this year with, again, sort of the constitution of symptoms of pancreatitis, nausea, vomiting, epigastric pain, inability to tolerate PO. And this is his MRCP and MRI images from that time. So you see on the MRCP on the left, he has a cystic collection in the tail, as well as some smaller cysts here, and you see the pancreatic ducts entering here, but also this tail lesion here, which appears to be disconnected and appears to be draining into this cyst cavity, and you can, it's not super apparent on the MRI image here, but you can see there.
Okay.
So,
yeah, so this is a good segue as well as to what to do with this. And if I'm summarizing this correctly, you have what looks like either a pseudocyst or organized necrosis with perhaps a disconnected duct, and what would be the management of that? At MCW, I see Osamu. What would you guys do there? And I know I see some of your mentors online, so choose your answer wisely.
Thanks. I think the two options, endoscopic option and the surgical options. So endoscopic option probably approach from Ampera to go across with stent, or alternatively, we can potentially go through the stomach, through the cyst to drain to the stomach. The surgical option would be draining cyst surgically or considering resection. In this case, a distal pancreatectomy.
So I know what the options are. What would you do?
I would try ordinary Mrcp to go stent across, or initially to see whether actually disconnected, whether we can go across with the stent. If we can put the long stent or go across and see how it goes. And if it doesn't work, and then I will move to another place to drain through the stomach. And then ultimately, the last option, the distal pancreatectomy.
Okay, so endoscopic treatment first.
Yeah.
How about Dr. Lee? WashU.
Hi. Yeah, I mean, I think that with a disconnected duct, the cyst is obviously not going to resolve without intervention. So I think that it's reasonable to try endoscopic treatment first. I mean, we have pretty aggressive endoscopists here too, to see if they can cross the duct and put a stent across. But if that's, and you know, we often try endoscopic treatment first as almost a trial of symptom control too. Because if they respond well to the endoscopic drainage and the pain gets better and symptoms get better, then it's often a good sign that they're probably going to improve with surgical management too if that fails. So I think I would try that first, and then if that's unsuccessful, you could consider doing a distal panc in this patient.
I'm just curious, you know, there was this procedure described as a Duval procedure, if anybody's familiar with that, which basically consisted of a drainage procedure and then bringing up a roux limb to the, you know, fistula tract or the cyst in the tail. Is anybody, maybe perhaps some of the faculty, anybody done one of those or still doing those, or?
So Flavio, I've had experience with this where we've had a drain in place that just won't quit draining, and I've just sewn a roux limb to the drain tract or the base of the drain tract, and it actually works. But we'll talk about benefits of drainage versus resection in this case.
Okay.
I think the main time when I've done that, I've done it a couple times, is when you can't do a transgastric approach, either due to location or because of gastric varices from splenic vein thrombosis. So bringing a roux limb to a cyst, if you let it mature and you get a nice thick wall, it's actually a quite pleasant procedure. But those would be really the main indications. Really, I think the learning point there is not to attempt transgastric interventions if you have gastric varices, and to really be quite close, because we've seen some horrific bleeds from transgastric stents for that.
But Flavio, you were referring to drainage followed by roux limb, correct? Not just straight cisjejanostomy, correct?
Correct. Yeah, correct. Yeah. I mean, I think the issue with these cases is always, you know, this is obviously a multi-step situation with that case. I think we would, for example, have drained those endoscopically, let that resolve, and then sometimes you can get away with having those disconnected ducts drain internally. However, the majority of cases end up, you know, patients are having persistent pain. There's that kind of floating tail that does require resection for long-term management. And as you said, the question's always when to get there before there's significant splenic vein thrombosis and sinistral portal hypertension. Any other thoughts? Anybody do anything different? Maybe Tim Newhook? I don't know if Tim's on. Nope. Okay. In that case, why don't we go on? Yeah, sorry, you on?
Yeah, I think I guess we'll move on here. So
okay, go ahead.
We decided to do a distal pancreatectomy and a splenectomy in this case, and confirmed that he did have a disrupted duct intraoperatively, and he recovered well from this operation as well. So in regards to management of disconnected pancreatic duct, this was a nice paper from the Indiana group. We looked at all of their necrotizing pancreatitis patients over a course of, I think it was 10 years or so. They had 647 necrotizing pancreatitis patients. of which 299 developed disconnected pancreatic duct. And they had almost even split of patients who underwent drainage versus resection, 111 drainage and 91 resection. And I think they do address in their paper the choice to do drainage versus resection. And this was dictated, one thing that hasn't been mentioned is the volume of the tail remnant. So in this case, this was a very distal cyst, and the volume of pancreatic tail or pancreas parenchyma that we were taking was small. However, if you have a more proximal lesion, I think a drainage procedure should be considered, because that's something that we should aim to do is resect as little parenchyma as possible as to avoid the long-term consequences of making them insufficient pancreatic function. And as was mentioned, the presence of portal hypertension, doing a simple drainage procedure is going to carry less risk of major hemorrhage as opposed to a resective procedure. And then they mentioned patient-specific symptoms, and this was something that I talked with Dr. Osman about, and what we thought this meant. And I think you have to consider what the patient what symptoms they're having, and whether or not their symptoms are primarily from compressive symptoms from an enlarged cyst. Are they having early satiety, gastric outlet obstruction from the cyst, in which case a drainage procedure is likely going to resolve that, or if they're having chronic pain associated with chronic pancreatitis, whereas resecting that pancreatic remnant probably makes more sense. So there's some things to consider. And then finally, they looked at the number of patients who initially underwent a drainage procedure and then proceeded to have a resection at a later date. So what I would kind of call a failure of drainage. And of their 111 patients, only 9 or 8% of them went on to have a resective operation, and all of which had a distal pancreatectomy. So I would say that using their selection criteria, they're actually doing a pretty good job with about 92% of their patients not requiring a second intervention. And we're actually looking at our experience as well of patients who from 2012 to 2020 who have undergone cyst gastrostomy. And we found close to the similar numbers. We had 13% who ended up requiring a distal pancreatectomy, well within the margin of error with these small numbers. So if anybody has any other comments about that, otherwise we'll move on to the next.
Yeah, I don't know if, is Brendan on? I don't know if, Dr. Visser, I know, has had some experience. Maybe Dr. Berquist can comment on their transgastric experience.
Brendan's not on, unfortunately.
Yeah, so I just wanted to say, I learned working with Dr. Visser, his approach to these cases with disconnected remnant has been to do a lap transgastric drainage procedure, which is where we basically do intragastric laparoscopy and then make a cyst gastrostomy on the posterior wall under ultrasound guidance. And it's a great procedure. It doesn't take that long. And the nice thing about it for patients with a disconnected duct is it actually provides quite persistent drainage. So the problem with putting an Axios in is that they usually don't leave them for very long because of the FDA approval or whatever. They have to take them out after a couple of weeks. And then usually the patient reaccumulates the fluid and they have the same symptoms. So when you do the lap transgastric drainage, they get persistent decompression of the isolated remnant. And he's actually written a few papers on that. So there is some data. It's not a clinical trial, but there is some data about it based on our experience.
Great. Let's get to let me hold off any further discussion. Let's get to the last case, because I do think the last one will kind of bring it all together.
All right, so our final case is a presentation of a 30-year-old female who had a history of multiple admissions for acute pancreatitis over the course of several years. Again, this is sort of a common theme, similar presentation. She, unlike the other ones, had no history of alcohol use, and also over the course of time underwent a lap chole. The episodes of her pancreatitis were worsening, and she was coming to the hospital almost monthly. She, like the others, was treated with pancreatic enzyme replacement as well as requiring daily narcotic pain medicines. And this is her CT scan. So, unlike the other cases, she has a significantly dilated pancreatic duct with calcifications within the head, dilated ducts, calcifications in the tail. This is whole gland disease. So the first case was isolated head disease and primarily tail disease. And now this patient has disease within the entirety of the gland, calcifications and a dilated duct. And we also got an MRI with the Mrcp, you see on the left here, large dilated ducts, looks like some distal strictures here. Joe mentioned her bile duct was dilated, but her liver functions, bilirubin, was all actually normal at the time of her presentation. And then here's her MRCP, again showing what we saw on the CT scan with the large dilated duct and atrophic pancreas throughout.
Okay, so let's see, with that presentation, let's see, Dr. Salibi of Atrium, what would you recommend?
So this patient obviously had a pancreatic duct stone causing obstruction, causing proximal dilatation. So with her persistent symptoms and what looked like was maybe a partial duodenal obstruction, looked like she had some dilated duodenum just adjacent to that area of inflammation as well. She's probably developing a chronic stricture in that area. She would probably benefit from a Whipple procedure, and given her proximal dilated duct, you could perform the whip stow as Patrick had mentioned in the beginning of his procedure. So you do a head resection and then open up the pancreatic duct longitudinally and do your PJ anastomosis in a longitudinal fashion in order to provide adequate drainage.
Couple questions in the chat. Anybody would do lithotripsy ahead of time for the stones, and any genetic workup for this patient? I'll start with you, Patrick, since you were just on.
So no, she did not have a genetic workup, and I didn't mention. So this, she had a pancreatitism, so she had a morphologic explanation for her pancreatitis.
Got it. So anybody would do anything different? Anybody would do a beggar or a pusto or a fry in this case and avoid perhaps the morbidity of a Whipple? Let's see, what do Kim and Vic do in Oregon?
Sorry, we had to unmute. So I've personally never seen or participated in any of those operations. And so just for familiarity, I think a pusto and a Whipple, like a whip stow procedure would be more kind of in line, because I technically wouldn't have the experience to do the others. So I think for the patient, whatever's going to be best for the patient, which is what you're familiar with, is probably what you should go with. That's my opinion.
Yeah, I agree with Kim. I think this patient needs a resection and a drainage procedure. I have personally never done one of these, so but based on what the symptoms are and the imaging, that would make the most sense, especially in somebody that's young.
Okay. All right. What did you guys end up doing, Patrick?
So, Fabio, before we get there, both Kathleen and Jinhee have both brought up genetics.
Mm-hmm.
Can they just enlighten us so that we're all on the same page? If one of the two of you would mind talking about that.
Well, you have a young patient that's non-drinker, non-smoker. I believe the age is 30. I mean, you've got to wonder what's actually going on with this patient, because it's whole gland disease. You have calcium throughout it. I bet she has a genetic defect, in which case she'd be referred for islet cell transplantation rather than go straight to resection and/or drainage.
And I totally agree with Katie about this. You know, pancreatitism typically doesn't cause this kind of significant change of the pancreas. It is uncommon to see that.
Well, it sounds like Dr. Barrows may offer islet transplantation.
I don't know about islet necessarily, but you could certainly consider it. Her whole pancreas is atrophic, but I guess I was just wondering if anyone, here, it sounds like maybe consider doing the total panc just because he's got pretty significant stone disease, which some of that you could potentially treat with the endoscopic lithotripsy. But I mean, I don't know if all of that will be just managed with a drainage procedure, I guess is my concern.
And it sounds like Dr. Hashmi from Calgary might offer a fry.
Halima, why don't you comment?
I was saying that because the calcifications were mostly restricted in the head, and it's a dilated duct, multiple stones, so I think you can take care of all those things with a fry, core out the head, and do a longitudinal, pancreatic with jejunostomy, removing all the stones. So I think that would be the least invasive, plus taking care of all the things.
And I would agree with that. In fact, that's something that we would, if this patient, again, pending the genetic workup, if that was negative, we would do that here and probably add a biliary bypass if there was a question of biliary obstruction. Let's just get quickly, we only have a few minutes left. Perhaps, Patrick, you can just kind of bring it home for us.
Yeah, sure. I think this is a great discussion. So we took her to the OR for a whipstow procedure, which was described by Dr. Jayaraja, which is a standard pancreaticoduodenectomy with a lateral pancreaticojejunostomy. So I have some intraoperative images, and I will be, to be honest, this is actually a different patient, but these were the ones that I had the pictures of. So this is us dividing the pancreatic head. You see the dilated duct and the resected specimen, and then we perform, just like you would on a pustow, a longitudinal opening of the duct here. And this is her duct, a nice wide opening to anastomose to. And you see us bringing up our roux limb and making our anastomosis here with the inferior portion. And then this is just to point out our technique in that we place two sort of crotch stitches at the right side of our anastomosis. So I think this has some advantages in that it's a simple running anastomosis. It's very quick to do, and we think it treats both the head disease and the tail disease. But in this case, there are many options. I think a fry procedure would be a viable option, and I think it was Kim Washington brought up that in this instance, I think the best operation for the patient is what you're comfortable with. What you do at your institution, we do a lot of duodenum preserving operations here, but we do a fair amount of whipples. This is an extension of a whipple operation. I think we're comfortable doing this operation here. So we're running out of time, but just a quick mention. There are a number of systematic reviews comparing duodenum preserving pancreatic head resections versus Whipple operations, and all of them come to very similar conclusions that there is no evidence of long-term morbidity, mortality differences, although there is some suggestion of benefit with the duodenal preserving pancreatic head resections with respect to short-term outcomes, shorter hospital stay, less blood loss. So as much as these studies point to that, I find it interesting that it's rarely encountered even in our AHPBA group. So few people have done them or do them. So, but with that, unless anybody else has any comments, I'm running out of time, so I can wrap it up.
Yeah, well, as always, Patrick, fantastic. We always run out of time, especially for these topics. So I'll give Dr. Jayaraja the last word.
No, thank you so much, Flavio, for a great moderation. I just put in the chat, just remember, in Sri Lanka, actually, we see this chronic pancreatitis that's to be tropical pancreatitis that has a high risk of malignancy with it. I don't know enough about the genetics around it, however, but thank you all so much for joining. Please make sure you pull the articles that Patrick got for you, and you remember the whipstow. It's a really fun operation, and you should try to do at least one of these during your fellowship. This actually works pretty well also in malignant disease where you've got a big gland. It's actually a nice wide drainage, and it's easier anastomosis than either a balloon gut or a standard Gliedman. Thank you so much.
All right.
Jill, our next presentation in December is what, Jill? Sorry.
Oh, no problem. It is going to be Johns Hopkins will be the presenter and University Hospitals will be the moderator. And Dr. Fischette, I see you on. You want to introduce your own topic?
Yes, we'll be talking about locally advanced pancreatic cancer and vascular resection and reconstruction.
Perfect. Thank you so much. We'll see you in December, and let's all be safe during the next few days. Thank you.
Take care.
Thank you.